I appreciate the opportunity of sharing some thoughts with you about this topic, how to treat 1/3 of breast cancer patients in the world with optimal therapy. The target in such treatment is having an alive patient at 10 years. When you see this image during this lecture, I'm trying to suggest that the information you're seeing and hearing is specifically directed at this patient outcome target, maximizing the chances that the patient will be alive in 10 years. How do you get the best for these of your patients? Women who are premenopausal with hormone receptor positive breast cancer. These are not abstract issues. They're very real everyday matters. These are our fancy words: efficacy, safety, efficiency. Our words technically in our technical language, but they encompass the key ideas that we have to deal with. The current high-income country standards for treatment of premenopausal women with hormone receptor positive tumors are impossible to meet and are not being met globally in very many people at all. It's because of big problems that I've listed here. The truth is that because of these problems, across the world, particularly in low and middle income countries, only very few patients who could benefit from good hormonal therapy and survive as a result of that therapy actually get these treatments. I want to suggest that the solution to our challenges in this particular patient group is surgical oophorectomy plus tamoxifen. You now have an opportunity to be much more successful with your patients. I will here address and support the assertions that you see on this slide. As you know, in multiple international trials, including ones I will talk about, medical suppression of ovarian function and surgical oophorectomy have been considered equivalent treatments, and both have been studied together. I did this trial in Vietnam in the 1990s, before that country had hormone receptor measurement capacity and any longitudinal outpatient care capacities. We collected tumor specimens and retrospectively measured hormone receptors. You're seeing here the results of oophorectomy plus tamoxifen in that subset of patients that were hormone receptor positive. These patients underwent same-day anesthesia, oophorectomy, and breast surgery, with the oophorectomy being done first. The risk reduction you can see at 10 years is an astonishing 0.65. That means 2/3 of the risk of dying were removed as a result of this treatment. It's important to add that we gave financial inducements for patients to return for follow-up, and we achieved a very high rate of patient adherence to tamoxifen treatment, which was provided for free. These are now the new updated data regarding the question of oophorectomy plus tamoxifen or tamoxifen alone. Following a magnitude of indirect evidence, we now have these complementary and rigorous and clear data indicating superiority of combined oophorectomy, whether by suppression or surgical, and tamoxifen over tamoxifen alone. You have very likely never seen any data like these I'm showing on this slide. So let me make perfectly clear what it is that you're seeing. These data are from planned secondary analyses, explanatory seeking analyses in patients in a randomized trial, all of whom were treated with surgical oophorectomy plus tamoxifen. You see here then 3 curves. The top curve, patients who by history were in follicular phase or the first 14 days of their menstrual cycle and had a confirmatory day of surgery low level of blood progesterone, confirming that phase. In the middle curve, you see the results from women who were in luteal phase or the second half of their menstrual cycle by history, beyond day 14 of their menstrual cycle, and who on the day of surgery had an elevated progesterone level, suggesting and confirming that indeed they were in luteal phase. It's the bottom curve that's particularly striking. These were patients who were beyond day 14 of their menstrual cycle and therefore historically in luteal phase, but they had low progesterone levels. And you can see their disease-free outcome was much worse than the disease-free outcome for patients in confirmed follicular or luteal phase. Here are the results of that trial showing overall survival. And you see a sustained impact of the situation of the timing of menstrual cycle phase surgery, such that in fact, at 5 years, there's a 20% worse outcome for patients who had surgery in the luteal phase, but the luteal phase was not confirmed. You might also call these patients long follicular phase or prolonged follicular phase patients. In a second trial investigating the timing of oophorectomy surgery in the menstrual cycle that we conducted in patients with metastatic hormone receptor positive disease, we saw the same adverse outcome for patients with low progesterone in historical luteal phase. You see that in the small dotted line survival curve, the lowest survival curve on this slide. You see that the median survival difference was 10 months. If I told you and talked to you about a trial where one treatment improved the median survival in patients with metastatic disease by 10 months, you'd be excited. You can see here that the outcome is much better if surgical oophorectomy is done in confirmed luteal phase or confirmed follicular phase. These two sets of trial results strongly suggest that timing of surgery is important. We have good data about secondary effects of surgical oophorectomy plus tamoxifen. These secondary effects numerically overwhelmed much more commonly talked about venous thrombosis, pulmonary embolism, and endometrial cancer effects. These adverse effects are, in fact, significantly rare in younger women, and in our data, significantly rare in Asian women. No such comprehensive data are available for LHRH treatment with tamoxifen or LHRH treatment with aromatase inhibitor. What you're seeing here is the results, bone marrow density measurements over time in patients treated with surgical oophorectomy plus tamoxifen. And the top darker straight line that you see between femoral neck bone mineral density of 0.8 and 1.0 represents the results for Vietnamese women, and the dotted line represents the results for Filipino women. Why the average results were so different in these patients is not clear to us. But what is important is that there was no change in the femoral neck bone density over time with such treatment, as you can see in both populations, and together they represent a significantly large study of bone mineral density. And this result is completely different from the result that has been seen with LHRH agonist plus tamoxifen, LHRH agonist alone, or tamoxifen alone. Most women in the world upload for a living, which means work. And these results with preservation of bone mineral density with this treatment are particularly salutary for them. What about the addition of chemotherapy? This trial reported over 10 years ago, a trial which was abandoned because of these results. No difference when chemotherapy was added to combination oophorectomy plus tamoxifen. At that time, the authors of the study wrote the 10-year results from this trial, and note they're 10 years, will remain for the foreseeable future the only trial data directly addressing whether such patients benefit from the addition of chemotherapy. Our results do not support the use of chemotherapy in these patients. And indeed, exactly a decade later, soft text trial data reported here, mid-range 21 gene expression recurrent score populations treated with either chemotherapy plus combination endocrine therapy or endocrine therapy alone, and in disease-free survival, overall survival, selecting out the highest risk score patients, there were no statistical differences in the 9-year follow-up outcomes. Population-based data are what are being shown in this trial, and you can see that out at 5 years, barely a quarter of patients are continuing to take tamoxifen. These data suggest the best possible results that we might expect generally across populations. And these results explain a major component of the suboptimal results I hinted at earlier. Using a common sense model of health behavior and using high-income country data about patient ideas, my colleagues and I think that we can correct the lost opportunities from tamoxifen non-adherence by addressing the critical information issues that you see listed here. in the context of particular patient goals and concern. We have to be clear to patients that hormone receptor positive breast cancer is a systemic illness. We have to deal with this issue of recurrence, yes, or recurrence, no. We have to deal with undetectability of subclinical disease chronicity with quiet and active periods. We need to emphasize the strong efficacy of treatment and the overwhelming beneficial secondary benefits. So let me summarize again the major take-home message of this lecture. There is a huge advantage of surgical oophorectomy because all patients who undergo the procedure get the treatment, unlike the situation with LHRH agonists, where patients at high rates drop out. There is, we strongly believe, a huge benefit of omitting a surgical oophorectomy when patients are not in confirmed follicular or luteal phase. You can see that the magnitude of the benefit from surgical oophorectomy plus tamoxifen taken for the 5 years, which is why I presented the data about thinking about increasing adherence. Here, I'm basically showing you the data for what might be expected with a population of half node positive, half node negative. And as I say, the factual survival of what's now happening in the world is, in my view, represented by the dark line. Luteal phase patients with low progesterone, or patients who are treated with LHRH agonists and tamoxifen, but never get the treatment or get only part of the treatment. Were we to apply timed surgical oophorectomy worldwide, and at least offer women this option, which often would be taken, we could save 100,000 women's lives a year. We need to keep our eyes on the target for everyone.